So, as we all know, Eisenmenger syndrome was first described as a pathological finding by Dr. Victor Eisenmenger in 1897. However, it was not till 1958 when Paul Wood first coined the term Eisenmenger syndrome in his now famous Cronian lectures. So, pulmonary hypertensive vascular disease is defined as a mean PA pressure of more than 20 millimeters of mercury with a PVRI of more than or equal to 3 Wood units. And most severe form of pulmonary hypertension, which is related to congenital heart disease, is what we call as Eisenmenger syndrome. And Paul Wood defined Eisenmenger syndrome as PA pressure, which is at the systemic level, with a high PVRI, with a reverse or a bidirectional shunt through any large communication between the systemic and the pulmonary circulation. So, what are the issues in patients with Eisenmenger syndrome? First and foremost is, of course, death. However, it is now known that Eisenmenger syndrome with pulmonary hypertension have better prognosis as compared to other patients with pulmonary hypertension. However, uh, there is a catch to it, and there is a lot of, and we'll discuss it in the further slides. And also, there is morbidity and quality of life is getting affected because of the high viscosity and low saturations. So first coming to mortality, as I said, traditionally it is believed that Eisenmenger syndrome have better survival as compared to patients with other forms of pulmonary hypertension. But the question is is this really true? Because if you see in pediatric patients who have Eisenmenger syndrome, the prognosis is not as great as adults with Eisenmenger syndrome. Also, most of the studies enter the day of enrollment in the study as 0 instead of the actual age of the patient, and this results in what we call as left truncation. So if you see the 10-year mortality, if you remove the left truncation, the 10-year mortality of Eisenmenger syndrome is close to 30 to 40%, and this is more so true for pediatric patients with Eisenmenger syndrome as compared to adult patients with Eisenmenger syndrome. The simple lesions with Eisenmenger, such as the PDA, VSD, and the ASD, have got much better prognosis as compared to the more complex patients, especially the single ventricle physiology and isomerisms, which have much worse prognosis in patients with Eisenmenger syndrome. So, what are the risk factors? If the patient is younger at age, so if you have a pediatric patient with Eisenmenger syndrome, has a much worse prognosis as compared to an adult patient. Patients who have complex congenital heart disease, transposition of great arteries, isomerisms, DORVs, AV canal defects have much more risk of death as compared to adults, as compared to the simple lesions. Patients with pre-tricuspid shunt, so ASD with Eisenmenger syndrome is much worse as compared to a VSD or a PDA with Eisenmenger syndrome. Lower baseline SATs are associated with high mortality and presence of pericardial effusion. As with every other form of pulmonary hypertension, presence of pericardial effusion has got worse prognosis in patients with Eisenmenger syndrome. Similarly, a loss of sinus rhythm, developing arrhythmias is one of the causes of mortality in patients with pulmonary hypertension. So, what is the causes of morbidity? And one of the most common cause of morbidity is erythrocytosis and hyperviscosity. Iron deficiency is very common in patients with Eisenmenger syndrome. Although their hemoglobin is high, they are more prone to iron deficiency. Bleeding diathesis due to platelet dysfunction, ischemic complications such as stroke, TIA, or embolisms, and infections, especially cerebral infections and infective endocarditis, are common in patients with Eisenmenger syndrome. Because of the high hyperviscosity, gout and hyperuricemia are very common. So what are the management strategies in patients with pulmonary hypertension? They can be broadly divided into two groups. One is the pharmacological management, which includes pulmonary vasodilators, and non-pharmacological management, which includes making them live a better life day to day. So we all know about this medications which are now available for pulmonary hypertension: endothelin receptor antagonists like bosentan, ambrisentan, macitentan, phosphodiesterase 5 inhibitors, prostanoids, selexipag is currently available, and of course combination therapy. So initially, in the initial years, there was a lot of apprehension in using this pulmonary vasodilators in Eisenmenger syndrome, because they also cause systemic vasodilatation in addition to the pulmonary vasodilatation, and there was a belief that it will increase the right to left shunt and make these patients worse. However, the first trial, which is the BREATHE-5 trial, which looked at the utility of bosentan in Eisenmenger syndrome, proved this hypothesis as wrong. And now most of these medications, except maybe selexipag, have been proved to improve morbidity and mortality in patients with in Eisenmenger syndrome. However, for the lack of time, we will concentrate more on non-pharmacological management, because I think that is the one which is is very important in patients with Eisenmenger syndrome. So adjusting their daily activities to meet new challenges, exercise and participate in sports, phlebotomy, management of complications, marriage, pregnancy, contraception, travel and non-cardiac surgery, and vaccinations and other medical care. And we'll touch upon all of these together. So first is exercise and pulmonary rehabilitation. It was initially believed that patients with Eisenmenger syndrome or any PH by itself, that exercise would have a negative impact and would lead to progression of disease and could cause sudden cardiac death. However, lack of exercises increases anxiety and depression, also increases the weight. Physical training improves endothelial function and improves quality of life. So this was the first study which showed efficacy of yoga in patients with pulmonary hypertension, and increase in 6-minute walk test was demonstrated in most, if not all, patients. Similarly, this is a multivariate analysis which showed that physical exercise improves not only social but emotional and mental health in patients with pulmonary hypertension and Eisenmenger syndrome. So what exercise should we recommend? We should highly recommend them to join a personalized pulmonary rehabilitation program, which is a dedicated 3-week program, and start with light aerobic exercises like walking and leisure cycling, upper body training with light weights. Swimming is always helpful, but never unsupervised. Yoga and breathing exercises are known to be effective in patients with Eisenmenger syndrome. However, the more important part is do not participate in competitive or adventure sports, because that's the one which can cause sudden cardiac death in patients with pulmonary hypertension. Phlebotomy. So it was initially believed that prophylactic phlebotomy is essential to maintain a hematocrit of less than 65%. However, this is a very, very major misconception in patients with Eisenmenger syndrome, as it does not prevent but in fact increases cerebrovascular complications in patients who have concurrent iron deficiency. So what are the indications of phlebotomy? If there are symptoms of hyperviscosity and in absence of iron deficiency, if the patient does not have iron deficiency, we have to prove and then only consider doing a phlebotomy. And in preoperative status, if the patient is going for a non-cardiac surgery, we can maintain a hematocrit, where hematocrit less than 65 would be essential. So these are the only two indications in which we would do a phlebotomy in these patients. Iron deficiency anemia and anemia is frequently ignored and missed, and because they are very, very blue and there is high hemoglobin, we tend to ignore this very, very important part of management in Eisenmenger syndrome. It also causes the causes of this could be menorrhagia, diet, and repeated phlebotomy are the most common causes. And active surveillance is necessary in patients with Eisenmenger syndrome, with biochemical markers such as ferritin, transferrin levels to be done at least once a year. Oral iron and folic acid supplements help treat and prevent iron deficiency anemia in these patients. Next question is marriage and pregnancy and contraception. And these are the most common questions which are asked. Can I marry? Can I have intercourse? Can I have children? And will my children have the risk of developing congenital heart disease or pulmonary hypertension? So as we all know, pregnancy is associated with very high risk morbidity and mortality, both for the fetus as well as the mother in patients with pulmonary hypertension. And maternal mortality ranges from 30 to 50%. This has, however, come down in presence of the new treatment strategies and the new medications which are available. Nevertheless, it remains a high risk in patients with pulmonary hypertension. And usually third trimester and postpartum period is the one which is associated with maximum morbidity and mortality. And multidisciplinary team approach, close monitoring is essential for a successful pregnancy outcome. Contraception, as pregnancy is high risk, avoiding pregnancy is imperative. Barrier methods are safe, but the failure rates are high. Hormonal methods, especially the estrogen pills, would increase the risk of thromboembolism, also increase pulmonary vascular disease. Progesterone-only pills or implants are more beneficial. Intrauterine devices are effective and safe, and however, they have a risk of vasovagal syncope during insertion. And permanent sterilization, especially of the other partner, may be the most safe and effective way of preventing pregnancy in these patients. Next question is travel and pulmonary hypertension. As we all know, in the current era, travel is imperative. However, they have to be told to avoid Areas of low oxygen, such as high altitude, anything more than 1,000 meters needs to be avoided, and deep sea diving also needs to be avoided. Road and rail travel is generally thought to be safe. Air travel, although cabins are pressurized in the current era, but the pressurization is not at sea level. It is, and the saturation increases by a median of 5% at cruising altitude at 30,000 feet. Baseline oxygen saturation at sea level corresponds to the desaturation and symptoms in mid-air. So what are the recommendations? They can be undertaken, but with some precautions. Supplemental oxygen has to be available inside the flight, and it is very, very important because in the current low-cost flights, low-cost companies, supplemental oxygen is not available in all the flights. So you have to make sure that it is available whenever the patient is traveling. Try to avoid flights with a more than 8 hours duration. Avoid alcohol and smoking, and keep himself or herself hydrated, and take frequent walks to prevent deep venous thrombosis. Vaccination is also very, very essential because all patients with pulmonary hypertension, we need to vaccinate with pneumococcal, H influenza, and the yearly flu vaccine. And to add to this, I don't know about COVID, there are no recommendations, but yes, we should ask them to vaccinate. Good dental hygiene and infective endocarditis prophylaxis is also essential. Uh, the patients with pulmonary hypertension are at high risk for other cardiac surgeries, other non-cardiac surgeries, and especially there are events during anesthesia. Here also, and teamwork between the anesthetist with the operating surgeon and the treating cardiologist is essential to prevent complications. The drugs which decrease the blood pressure should be avoided. Thorough pre-op evaluation, especially by a PH specialist, is essential, and identify high-risk patients and procedures. Patient self-help groups, they were nearly not existent in India till a couple of years back. Then we had a Living with PH symposium in 2020 in the mid of COVID. And after that, there is a Pulmonary Hypertension India, which is a patient self-help group which has been started. It has around 500 patients now, and they are helping each other living with pulmonary hypertension in day-to-day life. Pulmonary Hypertension Association in North America is a very vibrant group, and plenty of educational material is available on their websites, as well as these groups are very, very active on social media like Twitter and Instagram. Uh, this is a small app which we have trying to make, which will tell the patients about how to live with live actively with pulmonary hypertension. We hope to have a patient support group here, as well as we can remotely monitor the patient's activities and what is happening. The last one is a lung or heart and lung transplant, but as we know, the availability as well as the cost of heart and lung transplant is an issue, especially in a developing country like India. And patients with bilateral lung transplant fare much better as compared to heart and lung transplant. But the problem with Eisenmenger syndrome is a patient only with a pre-tricuspid shunt like an ASD. In these patients, they can get away with just doing a bilateral lung transplant and closing the ASD. But if you have a VSD or any other cause of pulmonary hypertension, it is found that it is better to do a heart and lung transplant as compared to a double lung transplant. Also, the mortality of patients with congenital heart disease and pulmonary hypertension, the survival or 5-year survival is only around 50 to 60%. And that is true for most causes of most lung transplant patients. So what is the management strategy? This is my last slide. In patients with Eisenmenger syndrome, so look at the functional class. If the patient is in functional class 1 and 2, just advise regular follow-up and the non-pharmacological managements which we have seen. And there is probably no role of targeted therapy in these patients. Class 3, start with an endothelin receptor antagonist or a phosphodiesterase 5 inhibitors. And if still there is worsening, then go for a combination therapy. In patients with functional class 4, we can try prostacyclin analogs plus combination therapy. And if that doesn't work, lung or heart lung transplant is the only option for these patients. To conclude, mainstay of the care is not to destabilize the balanced physiology in patients with Eisenmenger syndrome. Targeted medical therapy can improve outcome in patients with Eisenmenger syndrome. However, that is only a small part of managing patients with Eisenmenger syndrome. Phlebotomy has limited role. Avoidance and treatment of anemia is essential, and non-pharmacological treatment options are the more are the ones which will change the patient's life. Thank you.